Good afternoon, everyone, and welcome to the 2019 Harmony webinar series. My name is Christy Weeks, and I am the Business Development Coordinator for Harmony Foundation. Today's presentation will be facilitated by Dominique Condeveau on the TBI and Addiction Conundrum, Clearing the Muddy Waters. For those of you, hold on, there we go. For those of you who are new to Harmony Foundation, we are nestled on a 43-acre campus in the Rocky Mountains just outside of Estes Park, Colorado. Our Colorado residential rehab offers comprehensive treatment for adults and their family members. Who is Harmony Foundation? We believe that long-term recovery from alcohol and other drugs is possible. And how do we do that? As a place between two worlds, our location in the Rockies provides a safe and quiet respite from the pain of addiction. With 50 years of treating addiction, we have fostered a generation of long-term recovery who supports our clients and families for a lifetime. Harmony staff at all levels of the organization work together to create a community of recovery support that is long-lasting. We are located at the base of the Rocky Mountain National Park in Estes Park, Colorado, and we offer an evidence-based 12-step program that is gender responsive. To learn more about Harmony Foundation, we invite you to visit us at www.harmonyfoundationinc.com, or you can contact our admissions staff at 866-686-7867. As we move through, just a few housekeeping tips that we'd like to go over as we move through the presentation. You will be receiving an email within an hour after the presentation as an evaluation for the webinar. We will also be sending you a certificate by an email. It is 1 CEU per NADAC. But you must be actively engaged in the presentation for at least 45 minutes in order to receive that certificate. We use a system that actually tracks how long people are engaged in the program. So anything less than 45 minutes would not qualify for a certificate through NADAC. We can, however, provide you an attendance certificate if you need to jump off early. If for some reason you don't receive that certificate by Friday, you can contact me at cweeks@harmonyfoundationinc.com. We would like to thank PAX Counseling and Dominique for her time today and giving this great presentation. If you would like to know more about PAX Counseling, you can go to www.paxcounsel.com. We will also be providing a recorded version at the end of the session. So if you wish to receive it, just let us know. You can type it in the chat box to your right. So I'd like to take a moment and introduce our presenter, Dominique Condeveau with PAX Counseling. Dominique is a licensed addiction and professional counselor, a master addiction counselor who is nationally and telehealth credentialed. She specialized in working with addictions, trauma, grief, and neurocognitive disorders. Dominique's private practice, PAX Counseling, is located in Aurora, Colorado, and she also makes home visits and consults through the telehealth platform. I'd like to go ahead and turn this presentation over to Dominique. We will be answering some questions at the end of the session, so feel free to use your chat box on your right-hand side of your screen, and we will address those at the end of the presentation. Dominique?
Hi, Christy, thank you so much for the wonderful the introduction. I'm very excited to go ahead and present and talk about this very important topic that we are seeing walking into our offices. Substance use disorder and traumatic brain injury being the topic. So, there's a picture of me and that wonderful introduction. Everything is right there. So yes, I am a licensed addiction and professional counselor in the great state of Colorado. I specialize in addictions and trauma and neurocognitive disorders, primarily traumatic brain injury. And as you said, I do have a private practice that's located in Aurora, Colorado. I visit homes, and then I also consult through the telehealth platform. The reason that this is important is because this is such a multifaceted and an intense program to be working with people who are going through substance use, the disorder, and the traumatic brain injury, that we're looking at an entire environment. So I based my practice holistically to meet the client where they are at. Why are we meeting here today? Well, this webinar is designed to educate you, the behavioral health specialist, with a primer in treating co-occurring disorders of traumatic brain injury and substance use. With the similarities in the outward physical behaviors and the mental attitudes, differentiating between the two disorders sometimes has proven to be a challenge for many of the treatment providers, including myself. Following this webinar, I'm hoping that you will have additional information to better differentiate between the two, the addictions and the addictions and TBI, when you are meeting with your clients. So a little housekeeping in the beginning. I am not attempting to diagnose or treat. I am not providing any medical advice, and this is for educational purposes only. And the reason that I make that very clear is because I haven't met the person that you're working with, so I'm not able to speak specifically on them because I haven't been part of the conversations and the privy to the medical files. So this is the best way to go ahead and make sure that we're on the same page. I encourage questions, but again, I can't speak to the specifics of any one client. Some of the materials that are included may include interventions and modalities that are beyond the authorized practice of mental health and addiction professionals. Again, I am not assuming that there are any medical doctors on the line with us today, but again, it's just to go ahead and be very careful about the scope of practice. So let's dive in. Research shows that 67% of people in rehabilitation for brain injuries have a substance use disorder history prior to their injury. Approximately 20% of people who did not have substance use disorder problems before the injury are vulnerable due to the incident, whether it's an accident or acquired brain injury. And people who have sustained brain injury test positive for alcohol in 66% of car crashes and 60% of assaults. So when we look at this type of statistics, this type of research, what we could see is, was it a substance use disorder and then I got a TBI? Or was it that I had a traumatic brain injury when I was younger and the overwhelm has moved me to self-medicate with substances? So before we go any further, I'd like to go ahead and give you some definitions for these acronyms that I will be using throughout the presentation. NCD is for neurocognitive disorder. SUD is substance use disorder. ABI is for acquired brain injury. And TBI is for traumatic brain injury. So brain damage, we talk about that quite a bit. It was damage, brain damage. The true definition is it's an injury that causes destruction or deterioration of brain cells. We're going to be talking about acquired brain injuries and traumatic brain injuries. What we are not going to be discussing during this webinar is congenital brain defects. That is not included within the standard definition of brain damage or traumatic brain injury. So We're going to be focusing primarily on traumatic brain injuries. So what is it? It refers to the damage to the brain caused by an external physical force, such as a car accident, a gunshot, wound to the head, or a fall. And again, the underlying word that we should have put here is external physical force. So here's a nice chart because sometimes people ask, well, what about brain injuries that are caused by different things? Well, the acquired brain injury means means that we get it. It's not internal like the congenital brain defect. It's acquired is the overarching, and then we break it down into the non-traumatic brain injury and the traumatic brain injury. So non-traumatic brain injury is anoxia, which is starvation of the oxygen to the brain, infections like meningitis, strokes, tumors, metabolic disorders. The one that we're really going to be focusing on today is the traumatic brain injury. Now we have the open brain injury, which includes the penetrating injuries such as the assaults, falls, accidents, abuse, and surgery. A lot of people forget that surgery is a brain injury. That's why we're going into we're opening up the skull. And so that would be a penetrating. A closed brain injury, and this is the majority of people who come walking through our doors seeking help, is the internal pressure and shearing. So we're looking at assaults, falls, accidents, and abuse. So concussions are the most common type of TBIs. This is what we hear when we're listening to or watching sports, that they're under a concussion protocol, or that somebody at school went ahead and fell off the swing, and we're looking that would be a form of concussion. Penetrating injury, we just discussed that. That is basically anything that is entering the skull. Contusions is what we see as the bleeding that results from blows to the head. So if somebody went ahead and I can speak to this because my husband is bald, very handsome man, but when he's shaving and perhaps he nicks himself on the head, that is not called a contusion. It's when somebody is falling and they hit their head and they maybe scraped it. So if they were skateboarding or skiing and they ran into a tree and there's bleeding because a branch hit them as they had, hit their head, that would be considered a contusion. And then we have the diffuse axonal injury. This is the damage from tearing of the brain tissue. And I've given some examples: shaken baby syndrome and some bicycle, motorcycle, and car accidents. This is where we go ahead and see the majority of people coming into our office because they said, oh, yeah, I did hit my head, or no, I didn't hit my head on the windshield, but my head went forward and backwards, also known as whiplash. That can be considered a concussion, or excuse me, a TBI, because there was an internal shearing, the coup contra coup of a brain going back and forth inside of the skull. So what is not a TBI? And I want to make this very, very clear, is that a TBI is not caused by something like a stroke or a tumor, and it does not include damage to the brain due to prolonged lack of oxygen. So what would be part of prolonged lack of oxygen? Two come to mind right away that we may encounter, and one is those who are making the unwise choice to hang themselves, and if they survive that, there can be some brain damage done because of the lack of oxygen to the brain. And the other one that we see, and not as common as it used to be earlier in the days, would be, and I can't remember what the slang term, but like whippets. So those who are sniffing glue, those who are choosing to use inhalants as their drug of choice. This also would fall into the category of starving your brain from oxygen. So the DSM criteria, neurocognitive disorder, this is where we start. And I bring this because this is the foundation of the criteria that we are looking. Just as we have criteria for substance use disorder, brain injuries, neurocognitive disorders also have a criteria that must be met that we can put them in that category. So I put this very briefly. Now, for those of you who signed up before, I went ahead and there are some handouts, some PDFs that you are more than welcome to download. And in fact, I encourage it, that has the major neurocognitive disorder, mild neurocognitive disorder, and the specifiers all written out for you. So you don't have to, as a little bit more information, it's just so you don't have to go ahead and write down furiously your notes. We have major, which is a significant cognitive decline, and it interferes with independence in everyday activities. And then the one that comes into our office quite a bit is the mild. And this is mild to moderate cognitive decline, and it does not interfere with the independence in everyday activities. Okay. In a few slides, we'll be going over what everyday activities and independent everyday activities detail. With this diagnosis, it cannot be due to delirium, and it cannot be due to another mental disorder, so such as substance use disorder, major depressive, or schizophrenia. We also have to put specifiers on that. We specify, is it with a clinically significant behavioral disturbance or without? It's not accompanied with it. And then we also need to assess the current severity. And that is the severity that is walking in your door, sitting in front of you at that moment. Mild, which is difficulties with instrumental activities of daily living. Moderate, difficulties with basic activities of daily living. And severe, fully dependent. On this current severity, the majority of clients that you'll be visiting or you'll be working with, unless you are working in a hospital, would be mild, maybe to the beginning of moderate. Okay, the moderate are that classification right there. You are majority visiting them at their home or in a rehabilitation home, and severe would be fully dependent. These are the patients that are currently in the hospital. And in Colorado, right down the street, we have a wonderful hospital, Craig Hospital, that works with brain injuries, spinal cord injuries. It's a fabulous facility. But again, their specialization is the severe. Differential diagnosis. So this is really where we're coming in today to say, okay, what is the differential diagnosis? If I have somebody who's presenting with a substance use disorder, but I think that there's something else going on, this is where we go. It's the distinguishing of a disease or condition from others presenting with similar signs and symptoms. So the differential for traumatic brain injury, this again is very abbreviated, but the majority of points are here. And I encourage you that to peruse your DSM 5, the purple book that I know that you all have on your coffee table, just waiting to be read. The very first criteria, A, is that they must meet the criteria for the major or mild neurocognitive disorder. The second is evidence, it's medically documented, of a TBI with one of the following: loss of consciousness, post-traumatic amnesia, disorientation and confusion, and the neurological signs. And then that the disorder presents immediately after traumatic brain injury or immediately after the consciousness recovery and persists past the post-recovery period. Okay, so acute is 0 to 3 months, and then when we start in chronic, that would be from the 4th month going forward. I have worked with people who have had the TBI diagnosis, and they have moved through that, but we are still working with some residual effects of the traumatic brain injury years later. Here's the differential diagnosis for the substance use disorder or medication-induced neurocognitive. Again, the criteria is met for the major or mild neurocognitive disorder. The impairments do not occur during delirium, and they persist beyond the usual duration of intoxication and withdrawal. The involved substances and the duration and extent of use are capable of producing a neurological impairment. Okay, so with this, if we have somebody that's coming in and saying, well, I've only used aspirin, and again, I'm using a very old, that's something that's not as common that people are using, and they've only been using it a couple of times, the aspirin is not what is giving them the differential diagnosis for the neurocognitive disorder. This is talking about people who are using anything from their depression, their SSRIs, to maybe a neuroinhibitor like Neurontin or topiramate that is going ahead and causing some cognitive distortion or cognitive impairment for them. So we want to make sure, that's why we look and do a medical history to find out what medicines and what substances, supplements and vitamins, anything that they are ingesting that could be causing a cognitive decline. And the disorder is not attributable to any other medical condition, or it's better explained by another mental disorder. I spoke briefly about the medical documentation, and all this is doing, and again in the handouts, I went ahead and gave you an entire sheet, just going over it to make sure that you had that information. What is medical documentation? All it does is says that it simply confirms the presence of the TBI. It does not establish the impact of the TBI. Okay, all it is just saying, yes, it is documented that you do have one. And again, confirming that the injury has occurred does not shed light upon the effect of the injury on subsequent physical, educational, behavioral, emotional, and social outcome. The very last point is a lot for athletic trainers or parents or school officials, whether it's high school or university level, anything that has to do with the school. When you have a traumatic brain injury, there is impairment, cognitive impairment. And the reason that we have to discuss what the educational impact is because the person who suffered the TBI is going to need some time off. And we're looking to how do we create an accommodation for their education. This is the primary reason that they are going to school. But we have to go ahead and create something so we don't cause the student to either get further behind in his studies because of this injury, or we don't overload them and expect them to continue with their studies because they have this injury. I hope I made that clear. So again, you have another a document going ahead and actually printed this out for you just so you don't have to scribble your notes. And again, if you have any questions, please feel free to go ahead and put it in the question section. I'm very happy to say that Christy will be going ahead and monitoring that. Activities of daily living, and we're talking about walking, feeding, dressing and grooming, toileting, bathing, and transferring, the ability to go ahead and move from the bed to the chair or wheelchair, okay? When I go ahead and look at the next slide that we're going to be discussing, which will be the instrumental activities of daily living, okay? That's just a brief, I'm gonna go over that in just a minute, go back to this. When I go ahead and look at what is the normal development, what is age appropriate, I kind of break down that the activities of daily living, I would consider that a 5-year-old, a developed 5-year-old, would be able to go ahead and perform these functions. They're well on their way. If I have somebody walking into me or I'm coming and I'm visiting someone and they are not able to go ahead and maybe get their food from the plate to their mouth, I am definitely going to go ahead and put them, I'm going to start looking at saying that's more of a moderate to severe, because this is really impacting their everyday, the basics for them to go ahead and be a human, right? Dressing and grooming, selecting clothes and putting them on, and adequately managing personal appearance. Again, I know plenty of 5-year-olds who, you know, they get the basic concept. I mean, I've seen some very outlandish outfits, but they're making that conscious choice that this looks good to them. Now, if I have a older person, so let's say I have somebody that's 35, that is coming out and is not dressed socially acceptable, like they are wearing for the weather conditions or for the conditions that are present. Let's say that I have and it's unfair to put in Colorado because I see many people like this, but let's say that you're in Minnesota and you are going out in a snowstorm and that you think that shorts and a sweatshirt and maybe your Crocs or your open-toed Birkenstocks, that will get you, that's appropriate, that is something that is not, I look at that and I say, okay, let me find out developmentally where they are. And again, I'm assessing on a, what is developmentally appropriate. The age is developmentally appropriate. Instrumental activities of daily living. Now, if I was going to put this with an age also, age appropriateness, I look at this as by the time that you're 18, you should have a handle on these. And again, we think of managing finances, paying bills, managing financial assets. An 18-year-old, what we are expecting is that they have some grasp that that money, what the function of finances do. What's the responsibility to paying bills? Would I expect a 5-year-old to understand that? Absolutely not. Managing transportation, either by driving or organizing other means of transport. So were they able to drive before and now they're not able to drive? We need to go ahead and look at that. Or if they are a person who chooses not to drive, are they able to manage calling a Lyft or an Uber or catching the bus or calling a taxi or asking a friend or a family member, saying, hey, I need to get here, to understand how to manage their transportation. Shopping and meal prep, again, getting everything ready, that they know what a meal is. They know how to feed themselves. They just don't say, oh, I'm hungry, and go straight to the refrigerator. Instead, they know that there's a rhythm: breakfast, lunch, and dinner. Managing medications, again, understanding that if they are using medications or if they are using supplements and vitamins, that they know how to understand the directions for that. Or obtaining it. Do they know that they've been told, hey, you need X, Y, and Z, and then how they can go ahead and obtain it? I go to the pharmacy. I go to the natural grocers. I go to, I plan to go ahead and ask my doctor to help me get this medicine. Managing communications, I put telephone and mail, but as we know now, it's majority email and texting. And so if they can go ahead and understand how to communicate, and then just the basic house cleaning and home maintenance. It's cleaning the kitchen after you've eaten, keeping your space, reasonably clean and tidy, and keeping up with home maintenance. Now, I recognize that there are some college kids and some people who their idea of keeping their space reasonably clean and tidy is a little bit different than mine. But again, we're looking at that, do they understand the concept? So here are some more statistics, and this is actually from the CDC in 2010. 5.3 million Americans, approximately 2% of the population, currently live with disabilities related to brain injury. I know that this is actually a little bit more due to the fact that depression, and depression comes with a lot of the traumatic brain injuries, is our number one for people taking time off of work, that we are treating the depression and substance use disorder. Those are our 1-2 that we are working with when we are talking about missing time from work. Males are more than twice as likely as females to experience TBI, and that's due to kind of the impulsiveness of the male gender. TBI is most common among adolescents and older adults. It's a contributing factor to 1/3 of all injury-related deaths, and this next statistic was phenomenal. Direct medical and indirect costs of TBI is estimated to be $76.5 billion, and that is in 2010. We are now in 2019, so I know that that's actually significantly higher. And the most common causes are falls at 40%, unintentional blunt trauma 15.5%, car accidents 14.3%, and violence 10%. So this next slide is just to remind us the characteristics of addiction. Its inability to consistently abstain, the impairment in behavioral control and craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships. They just don't get it. They just don't recognize that they may be part of the problem. I'm hoping that we're moving them to be, that they will be part of the solution. Dysfunctional emotional response, cycles of relapse and remission. And as we know that without treatment or engagement in recovery activities, addiction is progressive and it can result in disability or premature death. So now we're going to go ahead and look at the brain injury symptoms and kind of looking at how they overlap with each other. We're going to be talking about the perceptual, the cognitive, the physical, and the emotional behavioral. Perceptual symptoms, it's a change in vision, hearing, and touch, spatial disorientation, the inability to sense time, disorder of smell and taste, balance issues, and heightened sensitivity to pain. Cognitive symptoms, difficulty processing information, difficulty expressing thoughts, difficulty understanding others, shortened attention span, inability to understand abstract concepts, impaired decision-making ability, and memory loss. The physical symptoms, persistent headaches, extreme mental fatigue, physical fatigue, paralysis, tremors, seizures, sensitivity to light, slurred speech, loss of consciousness, and sleep disorders. And finally, behavioral and emotional symptoms. This is the irritability and impatience, the reduced tolerance for stress, sluggishness, flattened or heightened emotions or reactions, denial of disability, and increased aggressiveness. So the next couple of slides is just kind of showing you brain injuries can be mistaken for addiction. This is not the total list. This is just a few things that can be mistaken for addiction. Impaired thinking, diminished judgment, impulsivity, depression, mood disturbances, personality changes, fatigue, sleep problems, decreased frustration tolerance, difficulty with balance and coordination, and short-term memory loss. Here on the other side is addiction mistaken for brain injury. Again, not a complete list. You'll see a lot of the same things that were on the other slides because, again, those two, very similar outcomes, but could be two different or co-occurring. Problems with learning, attention, problems with memory, disorganization, disorientation, that's two. Disorganization is time and items, and disorientation, space and location. Tangential comments, going off topic, inappropriate social behavior, lack of insight, lack of learning from one situation to another, difficulty problem solving, motivation difficulties, and difficulty on the continuity, of an idea or action, word finding difficulty, headache, dizziness, and then balance issues. So I was getting a little fancy with the diagram here, and again, just wanted to show it in a different way to show you how that they kind of overlap each other. Again, TBI, the open head wounds and contusions, and then on the addictions, the broken capillaries. I mean, can you have a broken capillary through a traumatic brain injury? Of course, there's always the exception, but more often than not, no. Short-term memory loss, problems with memory, and malingering. And I'm going to talk about malingering more at the end of the talk, but we have to go ahead and make a note that that's something that we have to be aware of. I can't remember the name of these two boxers, but it moves us into a term that we may or may not hear, and it's called punch drunk. We are seeing a lot of football players come out with concussive syndrome, and we are also seeing studies come out that their brain had been damaged post-mortem. So we're looking at their brains. And again, that's a whole different discussion, but it's something that I wanted to bring attention to, just to say, because a lot of times if you are working with people who played sports when they were younger, and that's a majority of clients that I see, that they've been doing something, anything as innocent as gymnastics, to soccer, to hockey, whether it's field hockey or ice hockey, football, not so much baseball. Every once in a while I get a baseball player that has hit his head pretty hard. But this is talking about having a cerebral concussion, repeated blows to the head, and consequently exhibiting unsteadiness of gait, hand tremors, slow muscular movement, hesitant speech, dulled mentality. A lot of times I have some people, especially when they're moving through detox and they're very irritable and they like to fight. I've talked to them about that, like what's causing this. And what I'm finding is that I had one young man tell me, you know, I like to, when I drink, I don't know what happens, but when I drink, I fight and I'm a brawler. And they were talking about his history, and he was telling me that in sports, that was his job as a defender. He would get into brawls, whether it was on the field or on the ice. And so that really kind of made me look at that. I need to pay attention to that. I need to put that into my intake, into my conversation in the beginning to find out, you know, what was their position? What did they do for sports? What did they, I had one person tell me that they loved to climb trees when they were a kid, and they would fall out. And we realized that that was could be considered a TBI at that time too. So let's talk about some assessments. And I put this up here because, again, these are the ones commonly that I use when I'm assessing for substance use: the CAGE, the SASSI, the audit, and SBIRT. There is an SBIRT for TBI. And so I encourage you, if that's something that you'd like to go further and look at, NADAC has a wonderful, NADAC and SAMHSA have wonderful resources to go ahead and look at SBIRT, the SBIRT protocol. And I'm just reminding people it's a screening, brief intervention, and referral to treatment. So if we think about when we're doing intakes with our clients, that's the first thing we're doing is we're screening. We're getting that information from them. And then we're doing some problem solving with them, that brief intervention of assessing where are they on that scale. And then the referral to treatment. Some of you do refer out to treatment providers. And others like me, I go ahead and I look at that. When I think of referral to treatment in my office, I think, okay, where am I? What kind of protocol, what kind of treatment modalities am I going to go ahead and employ with them? And just a quick reminder with CAGE, have you ever felt you should cut down on your drinking? Have you been annoyed, guilty? Do you use substances as an eye opener? This brings me to a helpful acronym that I use in my office. I've also included the full form in the PDF, so you're more than welcome to go ahead and use that. You can print that off. You can go ahead and look at it. And this is the tool that I use in the very beginning so I can go ahead and start assessing for a TBI. And it's easy. Like the CAGE. Have you ever been hit on your head or been hit on the head? Were you ever seen in the emergency room, hospital, or doctor? Have you ever lost consciousness, dazed or confused? Have you ever experienced any problems in your daily life? And when I talk about problems, since they've hit their head, I'm looking for headaches, dizziness, depression, difficulty concentrating, difficulty reading, writing, poor problem-solving skills, poor judgment. That's being fired from job, arrests, or fights. And I'm getting that directly off of the HELPS screening tool. And then the last one, have you ever had any significant sicknesses? So with that, again, that would be the acquired brain, under the acquired brain injury category. And we're looking at a brain tumor, meningitis, college kids when they're going off. I know that in Colorado, the majority of pediatricians, before the student is leaving them, is going off, that whether they're going off to a college or a university, they will still go ahead and start giving them the shots, the shot protocol for the meningitis, which I think is a fabulous I thank you, doctors, thank you, pediatricians, for doing that. I'm also noticing that a lot of the universities will not let you stay in their dormitories unless you do have proof that you've had the meningitis shot. And we're looking at strokes and seizures. The oxygen deprivation, such as heart attack, carbon monoxide poisoning, near drowning, and near suffocation. So little things that you can just go ahead and it sparks them to go ahead and say, oh yes, when I was 10 years old, I was playing on the ice on a frozen lake and I fell through, and I was, obviously they were rescued, but then we want to go ahead and look at that. If there was anything more significant, did they spend time in the hospital? Were they unconscious? Again, just more information, the better that we're able to go ahead and assist. Working with substance use disorders and working with people who have a traumatic brain injury, I am reminded that I need to have patience and persistence and perseverance, and I need to work on praising, and I need to also really talk about repetition. Just as we know that 30 days doesn't cure substance use disorder, 30 days of rest doesn't cure a traumatic brain injury. These are ongoing processes that we need to go ahead and heal the brain and heal the body. So it's to remind us again that patience is necessary. Persistence and perseverance. At the very beginning, a lot of these people don't have that. They are so overwhelmed that they want to give up. And so we are assisting them. We are helping them move forward. We also are the ones that are praising them along. We know that people come to us and gravitate if they are feeling that they are valued and acknowledged. And repetition, we're learning a new lifestyle. Anytime that we are learning something, we're creating a new habit, we're creating a new change in our life. Repetition is part of that. So here's some common problems after a traumatic brain injury. And we'll be going through each of them, but this is really where I am setting it up. We have thinking problems, the cognitive, emotional and behavioral problems, sensory problems, and physical problems. I put the stages of change because that also works with traumatic brain injury. And again, if you're working with somebody who has the co-occurring, the substance use disorder and the traumatic brain injury, this comes into play. Because a lot of times people come in denying their disability. I'm fine. I just had to shake it off and walk on. All right, but there's some residual effects. And then the contemplation, hey, maybe I am having something going on. Gosh, that's the awareness. The preparation is, okay, what are the actions that we need to go ahead and move forward on? Action is to putting that into play, and the maintenance, that is the lifestyle changes that we're talking about. So again, we're going to be going through this. I have several slides going through this. The treatment strategies. We're going to assess and treat thinking, memory, and mood behavior. We're going to be providing counseling and education to family members, ensuring the understanding of treatment plan and possible outcomes. This goes along with building, recruiting, and support, creating support family and the support team. Gosh, I said that wrong. I apologize. This is part of the responsibility that we have as counselors, working with people with substance abuse and with traumatic brain injury, because this can be very isolating, the depression in there. And a lot of people are very burnt out. Family members and support members are very burnt out on this. They've been working with this for years. They just don't know what's going on. And that's our job, our responsibility to go ahead and teach them, and educate them. Because if we have the knowledge, then we have power. We have the power to make changes and choice and move forward. If they don't have the knowledge, the lack of knowledge is what fear is based on. The more you know, the more we can go ahead and move forward. Part of the treatment strategies also is role playing. So we're actually teaching, we're educating on coping skills, prep, money management, getting involved in community activities. That's more on the socialization. And then we're constantly going ahead and assessing the cognitive skills. So let's break this down. And I'm very mindful of the time that we have 10 minutes left. So again, if you have any questions, please feel free to put them in there, and then hopefully at the end we can address them if we have time. Attention and concentration. These are a few of the treatment strategies that we can go ahead and bring into our office or when we visit people and work with them. Decrease the distraction. So working in a quiet room. Teaching people to focus on one task at a time. We are multitaskers. We pride ourselves in that. Sometimes we have to take it down, not just 1 or 2 notches. We have to break it all the way down, one task at a time. And we want to practice attention skills on simple activities, such as adding numbers, coloring in a coloring book, reading a paragraph. And it has to be in a quiet area so we can build up that stamina for more noise to come in. And we gradually make the tasks harder. So reading a short story or balancing a checkbook or working in a more noisy environment. Couple of strategies that I use with this is that remembering that when we were kids, when we learned how to read, we started off with simple picture books, then we moved to chapter books, and then we moved to bigger chapter books. Oh my gosh, and that was like really great, and we got stickers for that. Again, it's reading stamina. We had to do it when we were younger, and sometimes as we're building our brain back up, we have to remember that and be patient with ourselves. Just keep at it day by day. And if you look at it like a mountain, instead of making leaps and bounds, if you do one step, pretty soon you're already up that top of the mountain. Language and communication. Today, I have spoken pretty rapidly. So I want to make sure that when I'm working with someone who has a neurocognitive disorder or working just the beginning stages of the substance or the detoxification or rehabilitation from substance use disorder, that I remember that I need to take my tone down. I have to be very careful about my not talking down to a person. I want to make sure that I'm using clarifying statements in our conversation to make sure that I've heard them correctly and they have heard me correctly. That I do not speak too fast or say too much at once. This would be this webinar would be completely overwhelming to someone who has a TBI. And then also to learn how to develop a signal that will let the person know that they've gotten off topic. Okay, so a lot of times, raising your finger, or I like putting my hand over my chest and touching my shoulder. Again, we have mirror neurons, so a lot of times the person, if we say that this is our signal, that I'm going to go ahead and put my hand, I'm going to cross my hand over my heart and put it on my shoulder, that their body will recognize that, hey, maybe I need to go ahead and pay attention to something else. Again, that's an upper level role playing. I wish we had more time for me to go ahead and go into that. We have improved memory. We're really looking at structuring routine, daily activities and tasks. Educate on organization and a set location for keeping things. We need a routine. Where do you put your keys? Where at night? Where do you take off your glasses and expect to get them in the morning? When you come home, where do you put your backpack? Just so that when they are entering a place, then they can go ahead and exit. It makes routine, always gives confidence and control, especially when a lot of times they feel out of control. We want to use memory aids such as notebooks, calendars, computer reminder programs. This is not an ad for Apple Watch, but I really like the Apple Watch that's connected to the smartphone, because that helps a lot of people with timing. They can put their schedule on there. They can have special beeps and taps to let them know to move on. Devote time and attention to review and practice new information. That's basically the repetition that we're talking about. Planning and organization, again, exactly what it sounds like. We are learning how to make lists. We're learning how to take goals and break them down into smaller steps so it doesn't seem so overwhelming. Reasoning, problem solving, and judgment. This is where we are critical thinking skills. Again, this is kind of towards a month or two into working with the client, because if we start off with this, they will probably become overwhelmed. So basically, it's critical thinking skills. We're teaching them to recognize that there's a problem and what is the problem-solving solution. We want to help them understand analyzing the information or change the way they're thinking. And then we also want to teach the pros and cons list. And then the very last thing on here is impulse management, that we need to go ahead. Anger management and impulse management are two very big things that once we start teaching them a routine, then they don't feel so out of control, and then the impulse or the anger can be, because we can anticipate, we're teaching them to anticipate the changes. So again, the inappropriate, embarrassing, or impulsive behavior, this is where we are role-playing. We're providing clear expectations for desirable behaviors before the event. Preparation, role-playing, so huge, whether you are teaching a young child critical thinking skills and moving forward, whether you're working with someone who has to have some lifestyle changes with their substance use disorder, or someone who is trying to go ahead and get their brain working from a brain injury. When to refer. Lack of progress, oppositional resistance behavior, failure to move on leads to regression. The symptoms worsen, the inability to stabilize behaviors, the active substance use and abuse. It's beyond your scope of practice. There's a more appropriate referral, and malingering. Unfortunately, malingering is part of every day that we have to be aware of. Whether it's using the excuse to not go to work, oh, I bumped my head, oh, and I can't work, and they keep prolonging it without doing anything. Or, again, with the substance use disorder, and again, it's always tricky, but the malingering is something that we have to go ahead and be aware of, very back of our head. Now, I have 2 minutes. I wanted to go ahead just quickly. This case study, this slide right here, is showing that there was a TBI that moved into a substance use disorder, and the substance use disorder moved into a TBI that was causing. These are two co-occurring, but where it started, one started as a young athlete who, trying to medicate himself, used cocaine and alcohol. And unfortunately, the result was suicidal ideations started when he was right at the end of college. The second one, the substance use disorder, was a young person, a young woman who started drinking at 14. And then the TBIs came in with the physical abuse that she had. Her stepfather, was the one beating on her. Her boyfriend, that was a co-combative, so they were beating up each other. And she was using substances to go ahead and kind of numb herself up so she could go ahead and move forward and take care of her kids. And after the birth of her first child, along with these two diagnoses, she also had postpartum depression, which is a whole other topic, but that was part of that in there. So here's my contact information. I appreciate each and every one of you for taking the time and spending it this afternoon. If you have any questions, please feel free to reach out. I just ask that in your in the contact, or not the contact, the memo line, just remind me that this was the TBI webinar, and I'll be sure to go ahead and get back with you.
Well, thank you so much, Dominique. We really appreciate your time. I know we had one question from Kristen Compton. We can try and answer it real quick if you'd like, or she can reach out to you directly and have that question answered.
We can do both. I'd be more than happy to go ahead and do that.
So Kristen asked, can you speak to working and assessing for cognitive disorder when a client reports a head injury, but there is no medical documentation?
Very good question. So that sometimes there are times where I have people who come in and say, I went to the doctor, I was assessed for this, and they actually have the diagnosis of TBI. But then I also have people who come in and they say, what do they do? I just give me something that they go and they're playing or they're skiing or they're skateboarding. And you know what? I actually had a surfer who would fall. He would, the wave would come out and he would hit the sand, and that was repeated. Did he go to the doctor? No, but he was dazed by that. And at that time, we can't make the diagnosis of a TBI, a neurocognitive disorder, TBI. There's actually a code for a self-reported TBI. And I don't have that number off the top of my head, but I have quite a few people come in and they say, this is what's happened. That's why I do that intense intake to find out what their background is, and then I can line it up.
Okay.
Does that make sense? And I can answer that. Again, I'm not looking at the question, so I'm trying to make sure that I answer it fully.
It seems that you did. I'm sure if Kristen has any further questions, she can reach out to you directly and you can go deeper into that topic. At this time, we are going to kind of wrap it up. I want to, again, thank you, Dominique. For everybody listening, we do record all of our webinars and we're happy to provide you an audio recording. Please reach out to myself at cweeks@harmonyfoundationinc.com. I'll be happy to do that. Dominique also has her handouts available, so you can let us know if you would like those if you have not previously received them. Our next webinar will be on February 27th with Kathy Hawkins. She'll be talking about psychedelic drugs and addiction. So, Dominique, we are so thankful to have you kick off our webinar series this year for 2019. Anybody interested in the next one, your email should be coming out in the next week. Please remember when you receive your survey that you will be getting here within an hour or so. If you have any topic ideas you'd like covered or any suggestions, please include those. And on behalf of Harmony Foundation, we want to thank you so much for participating with our webinar series. Dominique, thank you.
Thank you again, Christy, and thank you to each and every one of you for spending the time.
You bet.